Hello and welcome to The Connection, where RLDatix's Chief Customer Officer Liz Jones and Medical Director Darren Kilroy are joined by leaders and colleagues from within the healthcare industry. In The Connection, we explore how people and technology in healthcare can come together to create great experiences and support patient safety. We hope you enjoy listening.
Hello, my name is Liz Jones and I'm from a company called RLDatix, and I am at the NHS Confederation, and I'm joined by two colleagues, Darren Kilroy and Leigh Malyon. And we today are going to talk about patient safety, productivity and people, not necessarily in that order, but what those three things mean when we bring them together, particularly in the context of a lot of the topics that have been talked about, both at conference this 2 days, but also more generally in the sector. And I wanted to start by explaining a little bit about this podcast and why it matters. So we're a technology company and we are working on a podcast series that really explores not only the context in which our technology is being used, but the very idea that actually we need to bring humanity into technology. And to do that, you probably need to have conversations that aren't about the tech. So on that note, I'm going to ask Darren and Leigh to introduce themselves and tell us a little bit about who they are.
Love to. I'm Darren Kilroy. I'm the medical director for RLDatix. I've been with the organisation for a couple of years now. Prior to that, I was what you might call sort of an NHS lifer, I suppose. I've been in the service for nigh on 30 years, initially qualifying in the early 90s when life was very different in the NHS as a junior doc, and went through a career progression in emergency medicine, went from there into medical education, sidetracked into research, then went down the sort of leadership management angle of life, and spent some time working down under, came back and sort of went through the ranks, I suppose, of leadership strata. NHS phase of my career as a medical director in the Northwest. And it's great to be on the podcast.
Fantastic. Thank you. And we'll learn a little bit more about your journey, because some of those concepts around productivity, patient safety and people are your lived experiences, I get, through that career.
For sure. Yeah, I'll come back to that.
Okay,
of
come
course.
back to that. So thanks, Darren. Welcome. Leigh, tell us a little bit about your background and what you do now.
Lovely. Thanks, Liz. Leigh Malyon, I'm the head of medics at RLDatix, so commercial lead for a number of the solutions that support our medics, customers and doctors. Varied career in the NHS prior to joining RLDatix about 8 years ago. So originally a nurse, a surgical nurse, and then HDU. On leaving nursing the shop floor, moved into practice development, so nurse education, and then HR. So sidestep into a slightly separate function within, but working with workforce and workforce deployment, really aligning the needs of the organisation from a staffing perspective with the capacity that we were working with at the time. That built an interest generally in the area. And then after working with what was allocated at the time, saw a great opportunity to actually do something outside of the NHS organisation that I was working more broadly, and subsequently moved to RLDatix.
Fantastic. So what I love about this is that we've got some real clinical experience. We've got experience over a number of years. And I guess you are both ably qualified to talk about actually where tech has to meet that junction with humanity. And again, we're going to look at that in the context, in particular, productivity, because I think whilst I've been here, if I'd have had a sort of fiver for every time somebody had said reducing waiting lists and improving productivity, I'd be on a Caribbean island now. So on that basis, it is interesting. There's really variations in what people think they're talking about when they talk about productivity, Darren. So just for the purposes of this conversation, what's your kind of definition? What do you think it is and what do you think it isn't?
Well, it's interesting, isn't it? I mean, productivity says it's in the lexicon at the moment of healthcare. Everyone's talking about making everyone more productive. I think for me, the simplest way to approach it is getting the maximum value out of the inputs you put into healthcare. You mentioned at the start about where you've sort of touched upon it in your own professional life. So as a junior doctor, I'm sure the same thing when you started out, as we were just rookies. And in that phase of being sort of in the belly of the NHS and in the engine room of delivery, concepts such as productivity, well, never heard of it, never thought about anything like that. You're looking back all those decades ago now, clearly we were part of a productive machine, we were part of it, but the concept of it was just non-existent for me. And it's interesting to me how, as the years have gone on through your career, whatever your role, whatever your discipline, you get to hear about productivity or efficiency or things of that nature, and it becomes more and more a part of your lived experience of working in healthcare. But in different phases of your career, I'm sure you're the same when you were in the NHS. Looking back, I must have wanted and tried to be productive, but it never occurred to me I was being productive. And looking back, I have no idea if I actually was or not. I just went to work every day, did the best I could and came home. Whether that made me productive or not, looking back, was somebody else's assessment. But the word was never mentioned. But I think for present purposes, I like to think of it mainly as squeezing the maximum juice out of what resources you've got, such that no time at work is wasted, preferentially clinically. So no time is wasted and no effort is wasted in getting the maximum yield out of the resources you have to hand. I think it's the simplest way to approach productivity in healthcare. You can make lots of analytical, abstract, research-based assumptions, and there's lots of research around productivity and allegories to industry and other things of that nature. But I think it's always helpful to keep things simple. For me, simple is maximum value for the inputs you have to hand.
So we're going to come back to this because I happen to know you and I have worked together for about a decade.
We have.
In one way, shape or form. And I know that if we cut you in half, your kind of motivations have always been patient safety and patient outcomes. And as a consequence, the people that you've had in your care actually within your teams. So I want to come back to that in a minute because the idea of squeezing pips, maximum value, resources, they're kind of like quite alienating language. We're going to come back to that in a minute, Darren.
Yeah.
Leigh, when you think about productivity and what you've observed of it, actually, where have you seen it well articulated, and perhaps when have you seen it badly articulated? If you have that example, please.
That's a great question. And just picking up on something Darren just said there, it can be emotive when you talk about productivity because people immediately think it's about squeezing more out of individuals. I think coming on 30 years working in healthcare in various forms, one thing I know to be true is that every clinician that I've ever worked with, whether that be nursing, doctors, they didn't join the service to do admin or to do tasks that weren't promoting healthcare for patients and making patients safer. So any clinician that you speak to, with the taking away some of the terminology like productivity quite often, it's about, do you want to do more of what you train for and deliver more? And that's an open door. There's an absolute appetite for that. Where we see real waste is where processes are sometimes overly burdensome, so too much paper, lack of visibility, so waste in the system, duplication of effort. Quite often we immediately think that there's not enough resource to go around. We say resource sounds terrible, but not enough people to deliver the care that's needed. Quite often there is more capacity than we expect, but it's just hidden. And it's not hidden intentionally, it's just bad processes.
Yeah. I think that idea that there's almost like this hierarchy of productivity, there's this concept of your personal productivity, which is just, as you say, the stuff you want to get out your way so you can do a good day's work, versus an organisational productive outcome, which we'll perhaps talk about a little bit, is a really interesting thing to explore. And we will talk about Julian Kelly's note, which I think was 16th of May or something, where in particular we talked about what's different now. And that leads me on to that, Darren. You were working in service during the COVID period. I don't want to dwell too much on that whole period, but at that point, in many ways, productivity was really straightforward.
It was straightforward. Well, a huge facilitator in that really was the fact that, as we'll probably all remember, in the depths of the COVID pandemic, lots of we went what we were called governance light, and lots of what were previously bureaucratic hoops to jump through in delivering care in the system were sort of pushed to one side in the scrabble to get whatever clinical outcomes you could get in very strange circumstances. And so in that respect there, on one level, the sort of becoming unfettered from bureaucracy enabled people on a personal level to become more inherently productive. And that was a very sort of stimulating, I've said this before, it sounds a bit counterintuitive, but it's a very stimulating time to be involved in healthcare because you felt a little bit more liberated to innovate in ways that you knew would make a difference, but bureaucracy usually maybe prevented you from fully exploiting. But I think it's important in terms of productivity in the pandemic, and you're right, we shouldn't dwell on it too much. But one of the important points around that phase of healthcare was that the outcomes were very focused on getting people safely through a horrendous illness. Mm-hmm. And in other ways, of course, the health system became catastrophically non-productive at that time because other things were probably quite rightly pushed to one side. So it was an exercise for me personally in having the ability to empower clinicians, managers, admin staff. Everybody came up to the fore, of course, to help to get us through that phase. And there was a sense within the hospital that I was working in at the time that people were maximizing their productivity because you were all getting behind a common goal and a common purpose, a singular purpose, and that was very rewarding. So that was an exercise in probably the power of what the potential is to get people to feel more productive. Again, the word wasn't mentioned.
Yeah.
It just inherently, looking back on it, was a productive time to be working in the service. But as I say, the important caveat around that is it was productive in a very singular fashion around a singular goal. And to replicate that across the whole panoply of required care is something that, regrettably, and we're not in a position to deliver in the healthcare system in this country at the minute.
Because basically activity, as we would describe it, is far greater than those fairly...
Absolutely.
Yeah.
The absolute game, the name of the game was to focus upon the health and well-being of those maximally afflicted with the virus, whilst also, of course, and this was the difficulty, trying to keep a track of all the harm that was building up in queues of other patients who weren't able to get the care they needed because you had to devote your resources to this singular game.
Yeah.
And that, of course, led to lots of, perhaps we can touch on this later, lots of associated clinical risks in the system, which even now we're grappling with as a nation.
Yeah. And so this is for both of you really to kind of reflect on together. But in terms of that concept of activity and the fact that now thinking about this idea that actually tech and humanity, there's a crossroads and the two should actually complement each other and certainly not jar. Language, I think, is part of that. So we will often talk about activity, but in plain English, do you think that we need to consider the language we're using more generally around productivity and activity so that it's the stuff that people talk about in real life? And how would you articulate that, both of you?
Yeah, we build up huge amounts of terminology that we would just never really use in day-to-day life.
Yeah.
So we talk about capacity and demand modelling, and we talk effectively there's a need and there's a demand, and how do we fill that with the capacity that we've got, with the resource that we've got there. And I think there's sometimes that language gets in the way quite often. And going back to, again, what Darren was saying earlier, I think part of the opportunity here is to remove some of the structures that we've put in place. And sometimes even the language prevents that. I talk to productivity to individuals and they really don't often know what we mean by that.
Yeah.
Yeah.
Well, it's been explored so many times, hasn't it? Like productive ward, the Carter productivity.
You're right. There's been so many examples of them in Leigh's, NHS life, never mind latterly, of all of these initiatives, as you say, sort of soup of the day sometimes, and it's like Emperor's New Clothes, whatever acronym you care to mention. But at the end of the day, as Leigh rightly says, you're in a situation whereby there are X million number of patients requiring care, Y thousand staff to provide the care. And unless you do something really interesting in terms of investment in that workforce, innovate to make new roles or new ways of working, there'll always be that dilemma between the number of things that require to be done and the number of people able to do them. I've witnessed over all my years, and Leigh, you'll be the same, any number of initiatives around ways to address that, using technology and using innovative workforce solutions in terms of what roles we need to have in the system. A lot of those have, I think, looking back, been sort of not excuses to do the right thing, but they've had good intentions. And speaking as obviously as a medic by trade, I saw, especially in emergency medicine as the years went on, new roles around me developing, nurse practitioners, specialist nurses, therapists, all great people, all doing really good work. But the thing that was always holding that back as becoming a nationally sustainable model was lots of these roles were quite niche. They required national investment in making them successful. And so for that reason, they've always been on the periphery. And we haven't really, I don't think, even now, we've got the long-term workforce plan, which we can talk about maybe later. But even now, we've got such a confused morass of roles that you can now do in healthcare. It makes it all the more difficult sometimes to be productive on that basis, because I started out, as I say, as a naive rookie back in me and Leigh's day, not that we're men of a certain age, but people of a certain age we are. I only knew junior doctors, more senior doctors, very senior doctors, nurses and matrons on the ward. And I knew about 5 roles.
Yeah.
That seemed to do for quite a while when I was growing up in medicine. And I look around now and there are probably dozens and dozens of roles doing versions of what I did alongside the junior doctors. And it's all with the best of intentions to address the problem as we've gone along in sort of matching demand to capacity and the ways in which we can get people to work. But it's become very difficult to see the wood for the trees in terms of what the real workforce need is now in the country. We can talk about it in terms of the skills required and in terms of the knowledge required. And we can try and then think about, well, do we fill those roles with traditional medical doctors and traditional nurses, or how does it all work? I still think even now we're missing a properly honest conversation maybe internationally, but certainly nationally, about what actually do we need to invest in to get this cracked. I've been around these conferences and these confederation meetings, other things like that for so many years now, and we still debate and still talk about the right workforce model. And we just, I think even now, haven't properly got a grip of it.
And we have got national guidance now that through the long-term workforce plan. And we have got, I think it's fair to say, the emergence of what ICBs are going to be and are beginning to be now, give some infrastructure to support that plan. Obviously, there's other parts of the system around education. But what's your sense of our ability to crack it now? And what do you think the barriers are?
We've been waiting for a long-term workforce plan for quite a while. And I imagine, putting politics to one side, this is the best version of it we're going to get, period. I'm not confident that there's sufficient political or organisational will nationally to actually realise its potential, because the demands it's placing on recruitment and sustainable training and development of the workforce. And I actually think the long-term workforce plan is a really great document because it gives us lots of clarity where it wasn't clear before. But the sheer practicalities, the operational practicalities of delivering on it are vast, huge. The scope of it is immense. I'll give you an example from it sounds a small example, but it actually manifests itself nationally quite quickly into something that's really difficult. You have to scratch your head about. There's a lot of talk about new medical graduates and new nursing roles. And even as we speak now, the majority of senior clinical teams that I've ever worked with, in terms of supervising junior doctors and medical students, they're at capacity now to provide good quality clinical supervision. If you don't do that, surprise, surprise, you're into clinical risk. And the amount of extra resource required in terms of, we talk a lot about job planning for doctors, and the amount of additional strain on job plans required just to supervise and teach and train the required new number of undergraduates puts most clinical teams beyond their capabilities. And finding ways to address that, never mind recruiting them, even finding operational ways to make that work in the system is really tricky. So, and that's just one example that's small of how realising the workforce plan becomes very challenging, let alone nursing staff and therapists and other roles.
So I'm going to take us down a bit of a tech route for a minute, because you just mentioned job planning, and I'm going to ask any listeners not to turn off if job planning doesn't sound like the most exciting thing that they've ever talked about, because we're going to change that this very minute. And what I want to ask very specifically is, when we talk about job planning, quite often it's a very personal thing to the clinician, and the technology happens, and that's a kind of like compliance activity, and there's a lot of emotion actually around it. And yet, fundamentally, Leigh, and I'm really interested in your experience here, it can define the ability to deliver care, whether or not that's waiting lists across a particular pathway. So have we got this really messed up? Are we having a completely wrong conversation with the medical workforce about this thing called job planning? Or do we need to just talk completely differently about what it is and what its job is?
Job planning is really exciting.
Okay, you heard it here
Done
first.
properly. Well, it's exciting because it does unlock and give us an opportunity to really solve a number of problems. When I speak to clinicians, they often tell me they're not able to work to the top of their license. They're inundated quite often with tasks or with activities that could be done by somebody else and allowed more time for them to care and do what they've been trained to do. Now, job planning is an opportunity to look at the individual skills, capabilities, and align that with what this service needs. Quite often, job planning is a retrospective look back, unfortunately, of what's been delivered in the past, and almost a sort of cataloguing that. It's got the opportunity now to really look at whole teams and say, how can teams integrate together to deliver a service, the needs of the service for the coming year or the coming period. So it is a step change in the way that this has been undertaken previously. It requires teams to come together, to be honest and open about what needs to be delivered. But yeah, an absolute opportunity, and will unlock enormous amounts of productivity.
I agree, Leigh. I mean, for me, in productivity terms, job planning is your friend. And I've seen, like Lisa said, there's so many examples of, because it lands badly, it's one of the phrases that you use, it lands badly in organisations. And so it's just a beautiful way of saying it's a total car crash when job planning is introduced into the language and the thinking, because it's approached in the wrong way by many in the NHS. And having worked in it many years, I'm speaking not in an adversarial sense, in a very honest sense. If you don't approach the issue of job planning in the right frame of mind, you're bound to switch off those who are required to be job planned. Because one of the commonest bugbears of clinical teams I ever was involved in as a consultant and then as a manager of consultants was the overworked sort of, oh, I never get out on time. I'm there all the hours and I'm never getting paid for this. These clinics take forever to finish off. All this kind of really important narrative, which is a shortcut for saying I'm doing 5 extra hours a week I'm not paid for.
Yeah.
I used to say to guys like that, this is where job planning is your friend, because it's actually designed to help you as a clinician to maximize, yes, your productivity, but also to flush out to your employer where there is a demand between what you're able to give and what they are currently draining off you.
Yeah.
And one of the most difficult things to get over the line in healthcare, where everyone is in a state of financial distress usually, is the case for new investment in extra staff. And there is no better tool to realize that objectively and in a sustainable fashion than a properly constructed job plan. Because if you have a team of 10 clinicians, all of whom are doing a few extra hours, as Leigh says, properly construct their job plans in a collaborative sense, fostering a sense of this will help us as a team, you can quite easily identify the resources required on paper or a virtual paper for a new member of staff to join you substantively in a matter of days. And that is unarguably the evidence that the finance team need to put their money where their mouth is and give you the resource that you need. Not only does that improve productivity because you've got more sustainable workforce, not doing extra hours and being exhausted, it also gives you a much stronger footing to match demand in an objective sense. But that is one of the areas where people forget. Job planning is a facilitator of productivity. And the difficulty, of course, consultants have, and I speak from having been one many years, is because there's been historically, and there still is, let's be honest, in the culture of healthcare, there's often a clinical managerial divide. There just is. It's international. It's just the way life rolls in the public sector. And if job planning presents an opportunity to change the dial on that a little bit, but it does demand a nuanced approach, because if job planning lands the wrong way by the management imposing it upon clinical teams, you're on the back foot and you're never going to fully realize the value of it. So I think at the moment, with all the talk of productivity, I think back in our day, back when me and Leigh were professional nippers, of course, job planning wasn't a thing. It never been invented. But now we are in an era of much more sophisticated dialogue. And the key to productivity is to use job planning. And I'd like to think across groups way wider than medical staff.
Yeah.
Because as we said before, around different roles, now there are many more people in the multidisciplinary teams in the truest sense of the word. You have to have the facility to job plan all those people, as many as you can, because they're working cheek by jowl every day in the units. To just job plan one element of that is helpful, but it doesn't maximize the productivity.
And one of the things that's talked about in the letter from Julie and Kerry was this idea that actually we've lost some of the discretionary effort the service ran on for a very long time. Thinking about that dynamic, the fact that, and I think that's a combination of things, isn't it? I'm interested in what you both think, but it's people who have been burnout or they've just got a different mindset post the last 4 years, as well as potentially generationally, people have got just different ideas of work and the concept of discretionary effort. So if that has changed, and let's argue it's changed forever, it's just something that's changed in our psyche, what role has job planning across teams got in terms of therefore eliminating that reliance on the discretionary effort, Leigh?
I don't see that discretionary effort has gone. I think there's an enormous amount of goodwill still and intention to do the right thing regardless of what resources are available. And individuals will all, I mean, from a nursing perspective, there's probably not a registered nurse around that at the end of the duty, if they felt that staying another 10 minutes, 30 minutes to actually deliver quality care and continuity, they'd absolutely do that. I think the job planning really does offer an opportunity to capture some of that, and more so outside of actually the medical workforce. So I've been undertaking a lot of work with allied health professionals, physios, OTs, and one of the common themes that comes back is actually it's incredibly difficult to put objective information around what size team do we need to deliver a safe service. Job planning has really been, since that was introduced to non-medical staff groups in the last couple of years, that's just opened up a completely new conversation. And that conversation isn't just about we need more staff, but it's about actually, are we, as I say earlier, working to the top of our license? We're using the skills that are available to us. I don't think that discretionary effort will ever go, but I think there's a responsibility and accountability on us to make sure that we are capturing that, making sure we're still operating safely.
I agree entirely. You're absolutely right. There is always that. And I think that's the essence of being a professional, isn't it, really? People in nursing, medicine, allied roles, inherently, you're a professional. And you're right, you wouldn't walk away from any situation where you knew you had to provide care and give help. What I think isn't right, you just touched on it earlier, is that there's a difference between discretionary effort and sort of heroes and angels and above and beyond and all these crazy words, which I don't think cynically, they're unhelpful, because the discretionary effort should be rewarded and remunerated.
And understood.
To just walk past that and assume that that discretionary effort will cover gaps.
Yeah.
Which is, looking back on my own early days, that's what happened.
Yeah.
And I know things have helpfully, culturally moved on. As a junior doctor working on the wards not a million miles from here, many, many hours per week, this is the year of the 70-odd hour week for me, I wouldn't have dreamt of putting in an exception report. I'd never heard of the such things. What the work required was just the work that you did until such time as you went home. And I never claimed any extra hours for any of that. But looking back, that was wrong, because that isn't a healthy employer-employee relationship. So discretionary effort is absolutely a cornerstone of being a professional, but we have to recognise that, back to the job planning point, capturing that is a part of responsible employment.
Yeah. But there's also an opportunity there, right, to think about, you mentioned exception reporting by way of an example, which is obviously a contractual construct to notify of an unsafe working practice that, et cetera, et cetera. It's also a communication from somebody who works for you about their experience of work. And so it may be a piece of tech, and it may be from a contract, and it may be part of a process, and all those really kind of things we just have to do. But it's actually a moment where another human is telling you what their experience of work is. That's priceless. And if you go back to even something like the incident reporting, which obviously we're all involved in through the RLDatix system, it's a communication. It's people talking to you about their experience.
Oh, yeah, it totally is, because you're right that at the end of the day, any piece of technology, from workforce to any technology, one of its main purposes to me is to foster or stimulate or cause a conversation between human beings.
Yeah.
Because you're right, the exception report's a case in point. One could just look at exception reporting, which for those who don't know is essentially you're scheduled to work a number of hours and contracted to do so for safety reasons primarily, let's say. If you are regularly triggering longer days than you are meant to be working, that will generate an exception report, which fundamentally will inflict a financial penalty on the employer. And that's important, but to me isn't the essence of what it's about. If you are regularly, and I remember dealing with these in the NHS, if you're regularly triggering exception reports and having to pay people and to work around that, it's telling you something about the welfare of those staff who are at the end of that report. And back in my days as a young doc, they didn't exist. We just did it until we had to go home, and that was discretionary effort, wasn't paid. We just exhausted and went home until the next day. That was, looking back, that was totally dangerous. Now we have a technological mechanism to describe that, but it's only as good as the people receiving the information and dealing with it. Like job planning, it's a stimulus to have a conversation regarding what you do all day, in the same way that appraisal is, or anything that involves technology. How many times have I sat, and Leigh, you'll be the same, you sit with rota teams who are putting in technology, be it an RLDatix solution or any other you care to mention, and there is often, let's be honest, a huge amount of dialogue, for want of a better expression, between junior doctors and the medical staffing teams around issues with implementation or understanding how things work in the system, and that's all to be expected. Even the fact you're having those discussions, which can sometimes be a bit tetchy between administrators and doctors, it's a dialogue about how you work all day, and that's inherently helpful.
Yeah.
And I go back to the fact that the rosy tinted spectacles of old, those days were not satisfactory.
No.
No one can pretend we've got it right. Of course we haven't. But the technology we have around us now is an important stimulus to dialogue between human beings, all trying their best to get care delivered.
Yeah.
And I've always been of the opinion that whether you're working in medical staffing or an HR department, or you're an administrator in this awful phrase, back office, which is a phrase I've never liked, like frontline. If you're on the front line, who's on the back line? Everyone actually is invested in delivering healthcare outcomes, whatever your role. And the technology provides a substrate to have conversations that will improve that.
Including patients and carers,
Including patients and carers who thankfully these days have got a much more prominent voice in the narrative. Historically, that wasn't the case, but it's all there as part of the push to have a conversation regarding healthcare.
Agree. Leigh, there's a data point that we can look at across, for example, exception reporting, where I think the average response time, if you look at the last 6 months, is 4 months to just say to someone, we've got it. And you imagine a scenario where you've raised something, but you don't hear anything for 4 months. And of course, it's an average, so there's going to be people who wait much longer. And I think those are things that perhaps we can be better at sharing with folks.
Yeah, I think the humanity in tech is about having that empathy and how's that going to be received. So, for example, with job planning, I'll come back to exception reporting in a second, but with job planning, as that's moved into additional staff groups, so allied health professionals and elsewhere, the most, without exception, every organisation that we've worked with has found that that's met with anxiety from the teams that are about to be, it's seen as a threat, it's seen as actually, what's this going to do to me and my role as presenter? And then unanimously, post-implementation, I found it a massively positive experience because it is that opportunity and that voice to be able to engage and set a realistic expectation of actually what's expected of me in this role and how can I contribute more to the service. Now, with things like exception reporting, when we plug this tech in, it's only as good as the use that you apply to it. So it's counterproductive to culture if you're going to put in tech like this and actually not listen to what it's telling you.
Yeah.
Most of these systems provide information and allow you to manage services and systems more effectively. If you don't use that information or respond to that in a timely way, then I think it's counterproductive.
I agree.
I agree. And I think one of the things, building on that, is that having data regarding your lived experience of working somewhere is a great way to neutralize a conversation with someone who you need help from to get something improved. It's pretty pointless to go to your line manager, or you can go to your line manager and say, I'm working too hard. And they'll say, what does that mean? If you can describe how you're working too hard in terms of the hours worked, the exception reports filed, the incidents, whatever, then the data is a facilitator to conversations, which is hugely helpful. And back to your point on incidents and the timeliness of that there, thankfully now we're in a position whereby nationally, we're by far not perfect, but we have the ability now to capture incidents pretty much in real time. And we have the technology to facilitate sharing of learning from those quickly as well. We've got a journey to go on, though, I think, in terms of incident reporting rather than workforce, in terms of getting everyone feeling more comfortable with participation in the narrative of incidents. Certainly in the medical world, there is still a huge cultural reluctance from many to really get behind the ethos of incident reporting.
It's where the blame culture
because there's a huge, like nursing, there's a huge sense of professional pride in what you do all day. Human nature has it that you wouldn't readily admit fault.
Yeah.
Because historically, we've had a situation where fault has been assumed.
Yeah.
And we're still, I think, working through as a country how we can change that for the better. Now, technology around incident reporting, risk and governance is crucial to that, because we've seen over all my years, when I first met the world of workforce technology as a customer many years ago now, as you say, when we first met, that was new to me. And it took years to get fully up to speed with feeling comfortable with using that. We're on a journey with incident reporting technology there, I think. And it's much more emotive in one sense than workforce tech, because you get into the heart of error and potentially catastrophic error by virtue of one's actions. Not meant, usually not malign, of course, but even so, error has occurred. And getting people to participate in those conversations is something that's important, but still immature.
So I'm going to kind of do a segue because I think it leads into this cultural thing. We're going to talk a lot, all of us, over the next few weeks and months, and there's a general election coming up, so it's going to be a hot topic, it already is, in terms of productivity and how the service can be more productive and all those kind of fairly alienating concepts. And we ourselves are talking about how we link service planning through to the clinical operations, i.e. the activity linked to the workforce, and then capture that kind of anchored in safety and all the necessary reporting that comes out of that. And my question is that when you look at that, how do you make sure that people get joy still at work? Because ultimately we need people to turn up to work, and we need the next generation to want to go and be trained. But by the time the long-term workforce plan comes along, I will be just about to be at the retirement age, I think. By the time it's delivered, all of it's 15 odd years. And so we need a generation of people going, these are the jobs I want to do because I am going to have joy at work. So how do you square processes, diagrams, getting it right first time, all this stuff with joy at work? Is that possible? And who's going to have that conversation?
I think you put the patient at the centre, or the service user at the centre of what we're trying to deliver here, because, as I say, every clinician I've ever worked with, ultimately the joy that they get from work, productive people being happy people generally.
Yeah.
For whether that's through tech, whether that's through culture, if you enable these pretty amazing individuals to deliver what the career they've chosen and support patients for better outcomes, that's where you get the joy from.
Yeah.
What we tend to do is make those roles more difficult through sometimes too much governance, too much bureaucracy, so going back to COVID, that was as difficult as the time it was. There was also individuals that actually found that they were delivering probably more of what they trained to do in that period than they've done before or since.
You're right. I would say from my own lived experience as well, and where we are now, the role of proper leadership in healthcare, not management, leadership in healthcare, is to take the centrally derived, regionally administered, trust-wide delivered requirements and obligations regarding all these words we use: productivity, efficiency, financial, all the words that are corporate in a way, and to translate that into something for people who are at different stages in their careers than that takes away the bureaucracy and the jargon and just enables them, as you say, to go to work and do what they enjoy. And if you give people the opportunity to go to work and do what they enjoy, and your job as a leader is to lift that work and translate it into something which ticks the productivity box, the financial recovery box, the operations, whatever corporate box you care to mention, that isn't in the purview of junior nurses and junior doctors and therapists. Because there's no greater buzz even now. I remember back in the day, there was no greater buzz for me as a new graduate in medicine on my first house job, before even foundation years were thought of putting in a cannula successful. I put 2 cannulas in the wrong way up when I started, and that in itself would be 2 incident reports, slam dunk. And looking back, it's a tiny example of that. It gave me immense satisfaction that day to do that. Later in your career, you think you can resuscitate in a team setting, polytrauma victims, kids who've been in car accidents, people at the end of life you can give palliative care to and relieve their suffering, all these nurses who are providing really great care around the clock as we speak now in hospitals across the land and beyond, therapists who are getting stroke patients back on their feet, occupational therapists who are helping elderly people to go back home. All these therapists and all these doctors and nurses right now are getting immense joy in their work every day, immense satisfaction. We don't help them if we foster a narrative of decay, deterioration, failure to deliver, poor productivity, poor financial outcomes. That's not within the purview of the people doing the work. That is the failure of leadership that we have in the system that enables that narrative to seed so widely. And on that basis, you would have to be on one level crazy to want to work in this system as it is portrayed. But when you get under the skin of it, it's still an immensely rewarding career in healthcare. It's immensely rewarding. Probably that and education for me are the 2 areas of professional life which are the most rewarding to be involved in. And on that subject there, as a technology company, we need to do more in reaching into the education sector and helping young guys that come after us when we'll be needing the care from them to understand how attractive a career this is.
Absolutely.
And how rewarding it can be. And we've all got work to do on that.
Yeah, and I think you're absolutely right that as part of the ecosystem, as tech providers, we absolutely need to do that. I was speaking to a doctor who'd said that you always remember your first incident report. Is that true?
Well, I had so many, I can't remember which ones they were now. But no, you probably can. I remember the first thing I did wrong. The cannulas was an early sort of trivial example. It's not trivial to the patient because they had a big lump on their arm for 2 days after. But I can remember the first patient who I knew I made a mistake on.
Yeah.
Now, interestingly, that patient whose name I clearly won't recall, but I can remember, in the setting that occurred in, the way in which that was resolved for me, and I was into my first few months as a doctor here, was a quiet chat with the boss.
Wow.
And that was just normal. This is early 90s. I'm aging myself now, but that was the way in which things were
I'm
resolved.
surprised. I thought you were going to say like 80s, Darren.
but
So rude.
Even years after that, absolutely true is that even I can think of examples from colleagues and my own personal practice from the last few years of healthcare life in the noughties and the 2020s, where there is an encouragement amongst senior clinicians in some quarters to resolve, in inverted commas, issues with a chat.
Wow.
Because that just reflects still the work we have to do in relation to properly resolving and gripping blame culture and incidents.
But that's so complicated because actually the humanity can be a chat. And so a chat is a good thing. the incident recording is the learning, the organisational and the system learning, right?
Yeah.
You've got to change that.
Having a chat about an incident.
It's a good thing.
It's a good thing. What isn't a good thing is making no written record of it.
Yeah. Indeed. Leigh, just for you, again, you've spent a lot of time in your career, in the latter part of your career around workforce, that intersection. And I know that you're a subject matter expert in terms of productivity, both in terms of what you've done within settings as well as within our organisation. Do you think that productivity and patient safety can be a dual mission and articulated as such to clinicians today?
I think unlocking productivity is quite often about improving efficiency. And efficiency means more timely care, which often means better outcomes as well. So I think absolutely there's an opportunity there to do that. Yeah.
No one goes to work, nurse, doctor, therapist, wanting to be unproductive. It's really unrewarding, isn't it, to go to work? And take surgeons. Most surgeons, if not all, want to go, and all they want to do all day is operate on people and do procedures.
Yeah.
They don't want to fill forms in to the point on workforce tech and any kind of thing. They don't want to be doing tedious admin in their sort of view of the world. And a lot of the safety issues that arise in what you might term a productive sort of environment, productive context, arise where unenlightened managers may interpret productivity as haranguing people or hectoring people to do things more quickly, which isn't productivity. If you're not careful, that's just stress on people. So the issue there about productivity and safety is quite straightforward to me. If you foster a situation where people can be maximally productive, they'll inherently be safer. Because if you just take the example of the way in which we flow through theatres in an acute setting, patients go into theatre and come out of theatre, and the operation takes as long as it takes. Now, most operations in reality, in most situations, you can predict how long they'll take to the nearest 5 or 10 minutes, unless there's a clinical exception on the day. But if the theatre scheduling isn't set up right, and too many or too few cases are listed, and there's a bit of downtime at the end, which is inherently unproductive, and other things then arise which themselves could be safety related. So they're inherently linked, but it relies upon, I'll go back to the leadership point, allowing people the time and the space to understand that being productive is what people want to be. As professionals, the discretionary effort, people inherently want to be productive and they want to contribute to where they work. If you allow them to do so and get the behaviours right around them and allow them to be practitioners, that's inherently the safest way to practice systems.
How do you link that through then to, because obviously safety is one of the outcomes, to do something productively and for it to be safe is an outcome, I guess. What about the other outcomes?
I don't know that safety is an outcome. I think safety is a given in all of healthcare.
Fair enough,
You wouldn't want to have a situation where safety was an aspiration or a measurable outcome. It has to be de facto safe.
Yeah.
Otherwise, you wouldn't want to enter into the building.
So how do you bring outcomes? Because outcomes are sometimes left out of the dialogue when it comes to productivity, because we talk about inputs, we talk about productive measures, but actual clinical outcomes, where do they fit into this?
Well, I suppose in productivity terms, you talk about inputs and outputs and then outcomes after that. I think that fundamentally, from the technology point of view, what's important is in any given software solution or any given product that a provider might care to procure and utilize, is that inherently to maximize the outcomes, you need to be diligent and tenacious regarding the inputs and outputs.
Yeah.
Because otherwise, they will become the rate limiting step of the higher level outcomes that you need to demonstrate. And so it's absolutely important. If you take an example, I'm making it up now, of job planning, say, or a rostering of doctors, the fill rate of shifts, the skill mix of a shift, of a unit, of a service, that skill mix is crucial to maximizing the quality and quantity of the outputs of the software. But it isn't of itself an outcome. The outcome is waiting lists go down, cancer care is delivered in a more timely fashion. Around and about all that, of course, there is an inference that safety is the golden thread. But I think we have to be realistic in healthcare, like many other sectors which have got human beings in technology and close collaboration. There will always be mistakes in healthcare. Show me a doctor who says they've never had an incident and I think they're dangerous. They're either lying or they haven't done enough. And there will always be mistakes in healthcare. Our role in technology and in service provision, all of us, is to recognize those mistakes as quickly as possible, share whatever mistake has happened in an equanimous manner and learn from it quickly, and share that learning so we minimize the chances of recurrence, but we'll never eliminate them. And to pretend or aspire to a zero harm healthcare culture is going to be fundamentally exhausting. but we can aspire to a system and provision of care where we aim to reduce, if not eliminate, avoidable harm. And that's the name of the game. But there will always be blips in safety. No matter how productive and how efficient we are, safety is always going to be something we have to be hungry to make sure we're gripping onto that.
We're getting towards the end now, and I wanted to ask you both a question. If I could take you back to when you were customers of our organisation, of RLDatix, in its previous formations of Allocate and Datix, for those that don't know. But if I take you back to those days and you imagine that those days are now, and you are working with us, and we've got a responsibility to you as a vendor to do the right thing, to make sure that we help with that intersection. We don't just come and nail some software in and tell you it's going to be a miracle at the end of it. What would you be asking us to do? What would you expect of us to support you with the productivity agenda today? And therefore, what should our organisation and others that may listen to this be really focused on doing to help the service?
The tech gets you so far. So the tech's a facilitator, an enabler. Just plugging it in, turning it on will do very little in and of itself. What does is actually using the outputs and the information that gives you, and adapting your processes and adapting the governance that you've got in the organisation to respond to what those systems are telling you. So are the board asking the right questions? Are they using the right data? Are the right measures being seen frequently to see if we got continuous improvement? So there's a wealth of information there. I think the onus is on RLDatix and providers of technology like this to not only say this is how you configure it and how you build it, but actually how you use it on an ongoing basis.
I agree, Lee. And I would say, for my contribution to that question, Liz, would be this, is that if you're a junior nurse, doctor, therapist, any role you care to mention, up to a manager, an exec, a non-exec, you could say to the technology company, I have a job I'm doing here. I like to think it has a golden thread leading to better patient care and population health. But I have a role to do. If I'm a junior doctor, I'm doing this role. If I'm a therapist, doing that role. I can do my job without your technology. I can, because back in the day we did. And I see that you've got whiz-bang fancy products that you can now add into my life. But I want you to help me, technology company, explain how that will make my life better and enable me to deliver better outcomes. What I don't want you to do, technology company, is to come in and make my life exhausting, frustrating, and tedious because I have to grip around your solution and make it work in my world. I'm already doing this job. I'm busy enough. And it sounds like your solution will help me to do it better. So tell me how it'll do it better. And then I'll work more effectively and productively. And that's a win-win.
Absolutely. And Darren, I completely agree with you. And I think at a point now where the technology is leaping forward so much, we ourselves have got some really exciting stuff happening around instance and AI. At that exact point, we need to do that more than we've ever done that historically, because actually that intersection between people and the machine is about to profoundly change, actually. So
it really is.
Agree.
Because, we even at this conference that we're at now at the ConfedExpo, of course, there are displays of robots for surgical robots. Now, a surgical robot will very nicely remove your prostate or do any number of procedures to you, but it won't break the news to you that you've got cancer. That's a human being. So we're in a very complex healthcare environment, as you rightly say, with all kinds of additional nuances and all kinds of additional complexity we have to grapple with every day. Technology has to ease that congestion if it's going to be truly successful.
Absolutely. So we are getting towards the end now. It's really hard to summarise this. I think our ambition was to come here and to start a conversation, which we're going to have with lots of different people, about how we humanise technology in the context of the challenges that our customers have got, actually not just in the UK, not just in the NHS, but actually elsewhere. And we've learnt some stuff. And the things that I've come back to in listening to you both and your vast experience is actually this idea of language and the lexicon we use around the things we're trying to solve, whether or not that's from a solution perspective or even describing what the problem is to be solved. So I think there's a lot that we can do there. Leadership, as always. And I think you described that brilliantly in terms of part empowering and also getting out of the way of people, and learning, which was kind of inherent throughout everything that you all talked about. We also learned that Leigh is insistent that job planning is exciting and
can be
very stimulating.
So we'll perhaps cover that one in the future. Is there any last thoughts that you would want to share beyond that summary in terms of this piece?
I think you're summing up, it captures it perfectly. But there's an opportunity here that when organisations use technology, they're quite often in such a rush to deliver the result. They don't always bring the teams along with them. So I think you're absolutely right. It is communication, it is leadership. And it will be an open door,
Yeah.
but bring the clinical teams along with you. It's quite often feels as though solutions like this that are just done to people.
Yeah.
It's one of the common themes that we hear.
Yeah.
Always better results if you do it collectively as a team.
And that's why the podcast is called The Connection, because it is about actually connecting people. And hopefully we'll explore more of that over the weeks and months. I think something very, very final thought is something you said that to me feels like if you could actually describe a mission in terms of this kind of the human interface with the tech, is that idea, this ambition that we make these the most desirable jobs, the ones that people want to come and work in.
That would be my closing reflection. Just pick up on Leigh's point there. I think almost, it sounds a bit grandiose. We have a civic responsibility working in this industry, either in tech or in care provision, to share the enthusiasm and energy and positivity around that with young guys, young people. And we still need to do a lot more around that. We should be into schools and colleges, universities, libraries, any civic setting you care to mention, helping to spread the word of how great it is to be involved in this career and this profession, because it's a hugely underestimated part of getting this cracked. And there's a lot we can do around that.
I agree. I think one of our podcasts coming up will bring some people in who are of that generation and maybe hear from them, because they'll bring a different perspective, won't they, to us? Okay, brilliant. Folks, thank you so, so much. Hopefully that was interesting for everyone listening. And hopefully you will join us in some of the future podcasts with my colleagues.
Hope
Thank
so.
you. Okay.
Cheers.
Thanks.
Take care, guys. Bye.
Thank you for joining us on today's episode of The Connection. We hope this episode has provided you with valuable insights on the role that both technology and people play within the healthcare landscape. For more information and resources, visit RLDatix.com. Don't forget to subscribe to The Connection on Apple Podcasts, Spotify, or any other podcast platform you use. Join us next time as we continue to explore how healthcare is impacted by connecting people and technology. On behalf of the RLDatix team, thanks for listening.